Hello, this is Dr. Wendy Wood, and we're going to be talking about body system changes with aging, beginning with the skeletal system. We first want to look at osteoporosis and differentiating that from osteopenia. And then we want to look at degenerative joint disease and 3 diagnostic markers. And we want to compare how this is different from normal aging joint changes. So beginning looking at the skeletal system and osteoporosis, this is what it looks like. So you can see this picture, and what we see is a decline in stature of about 2 to 3 inches on average, decreased fluid in the disc and the vertebra, which could account for this loss in stature, increased kyphosis and bone loss of the jaw. We also see bony changes with aging, so reduced osteoblastic activity, basically the reduced building. After age 30, we see about a loss of 0.5% per year of bone. At menopause, this is accelerated greatly to about 2.5 to 3% per year, and that's selective for trabecular bone. Women lose about 40% and men 30%. And many are asymptomatic unless a fracture occurs. So osteoporosis is defined as 2.5 standard deviations below the norm. And that would be in terms of the DEXA scan. So that's a bone scan. In terms of exercise, athletes can have 40% or more bone to start with. Weight-bearing exercise and resistance training is important. Calcium is recommended about 1,200 milligrams per day, and vitamin D with this. Again, we need to be very important. Let patients know that prescribing medications, including vitamins and minerals, is not within our scope of practice, but we can educate patients. Patients should limit meat and caffeine, reduce stress, alcohol, and smoking. And then estrogen replacement during menopause is controversial, but there's a lot of evidence out there to suggest that this can help decrease bone loss. Categories of intervention, if we look at 3 categories, those at imminent risk of fracture, so people documented with prior fractures, really need to exercise one-on-one with them, and weight-bearing exercise is very risky. So we need to instruct them in safety, fall prevention, and ADLs, and avoiding trunk flexion. Those at high risk that have a loss of height and kyphosis, we need to do a careful program of exercise. Those with normal risk, we need to gradually progress exercise, but do weight bearing. Joint changes that occur with normal aging. With hyaline cartilage, there's a reduced amount of water with age, so there's a reduced ability to dissipate force. There tends to be fibrillation, so cartilage begins to kind of basically disintegrate, and the surface appears more frayed. Early changes probably result from decrease in proteoglycan. There's also reduced hyaluronic acid, so that leads to increased friction, and increasing amounts of collagen and decreased elastin. So overall, what we see is a thinning of cartilage and a decreased joint lubrication and increased joint stiffness. Osteoporosis, that it would be the same as a degenerative joint disease. It was once thought to be a normal process of aging, but it really has been determined to be not a normal process. So there are more severe degenerative changes of cartilage seen that are not reversible. And there's severe collagen weakening and more of a reactive hardening or sclerosis of subchondral bone and osteophyte formation. So osteoarthritis or degenerative joint disease is the second most common cause of disability in the older adult, and it affects about 85% of those 70 to 79. It's common but not normal aging. So degenerative joint disease diagnostic findings tends to be subchondral sclerosis, reduced joint space, and osteophytes or spurs. And here's a radiograph. You can see the fraying. You also see the decreased joint space here. Clinical care, what we need to do is we need to have precautions with with weight bearing. So we want joint protection. The question is, if weight bearing is avoided, how do you prevent accelerating osteoporosis? What physical therapists need to do is exercises with joint protection, so low impact activity, and realizing that activities like jogging actually place 3 times more greater force on the joints than walking. Compression of cartilage is necessary, but we don't want to have overjarring. Now shifting to the nervous system, we want to look at sleep patterns with aging and also what happens with nerve conduction velocity. So first of all, the brain, we talked about this a little bit before with cognitive changes. This is looking at a demented dog and a human in this picture over here. But what we generally see is a decrease in brain mass of about 10 to 15%, mostly loss of white matter, myelinated structures, and dehydration. We also see ventricular hypertrophy. You can really see that in the dog here. Gyral atrophy and decreased myelin. So there's cortical neuronal loss. Not evidence with normal aging, however. Cortical neuronal loss is seen with dementia and subcortical neuronal loss, lipofuscin and debris. These are some of the markers, transmitters. We talked about this with dementia in a prior lecture. The neurofibrillary tangles, the neuroneuritic plaques, and the Lewy bodies. Those are all things seen with dementia. Those aren't normal. With neurotransmitters, there tends to be a decrease of about 15% in GABA. So that could lead to progressive deterioration of fine motor coordination. And acetylcholine, that's associated with learning and memory declines. Dendrites and synapses decrease with age also. Functionally, the changes we see are reaction time is slowed. So this could account for a slower transition of information, could be the reason for this. Reaction time is consistently slower with elders, about 20% slower for a 60-year-old as compared to a 20-year-old. And training does not significantly increase reaction time. There's no significant change in conduction velocity, though. Sleep patterns. 25 to 40% of older persons complain of sleep patterns. Sleep tends to be lighter and shorter, and there's multiphasic sleep cycles. Normal changes are often medicated, so a lot of these patients are on sleep medications. With peripheral nervous system, it tends to be in a decrease in the Meissner and Pacinian corpuscles for sensation, and a decrease in afferent nerve fibers. So that could be another reason why reaction time is slowed, because there's an increased internodal length and a decreased conduction velocity. So let's go ahead and look at the control systems, hematological changes with age, CBC. What are the normal ranges? We talked about this already. Endocrine changes seen with age and how those affect patients. So let's look at the hematological changes. So there tends to be blood counts don't change with age in a healthy individual, but there's a high prevalence in anemia in the acute and the long-term care settings, probably due to the patient population there and perhaps the care. When the body is stressed, the bone marrow has a hard time keeping up. So You need to really watch for patients with chronic bleeding, like especially GI bleeding. Watch for anemia. And don't exercise patients with a hematocrit less than 20% or hemoglobin less than 8. With the urinary system, the kidney's rate of filtering is reduced, and the bladder capacity is decreased too, both of these by about 50%. There's a real impact then with drugs clearing the system, especially penicillin, tetracycline, and digoxin. And there's a decreased capacity to absorb glucose and decreased ability for concentrating and diluting ADH. So this leads to more of a risk for dehydration and hyponatremia. And organ systems do dramatically deteriorate with age. So in the older adult population, you're seeing about 50 to 30% incontinence. About 50% of skilled nursing facility patients have problems with continence. The GI changes. There tends to be a decrease in digestive acid after 50. Gastric ulcers and inflammation are more common. The intestines decrease in weight by about after age 40. And muscle tone of intestines decreases, so we tend to have more constipation. But there's a great deal of variation with decline. The liver, diminished detoxifying ability, so the drugs are going to remain in the body longer. So older adults usually need smaller doses. The immune system tends to decline with functioning, and there's increased susceptibility to disease. And stress can cause a decline in immunity. So there's increased infections, cancer, and autoimmune disease. And the clinical signs of infection are diminished, so that's important. Elders often don't run a fever, but they present with confusion, a fall, or disorientation due to an acute infection. Thank you, and that is all for this recorded lecture.